Hello, and welcome to part 1 on chapter 17, the endocrine system. For our class, we're going to stay focused on the section of this chapter that devotes its attention to diabetes mellitus. A little bit of history of the name, because it gets confused for this other condition, and let's just get this out of the way. Diabetes comes from the Greek. It means that which passes through a siphon. So it's referring to the fluid that is taken in by a person and then it comes out as urination. And the reason it got this name is from this key symptom that comes up with diabetes, and that is increased urination. The term mellitus comes from Latin. It means sweet. Those of you who speak Spanish know that the word miel means honey or something that is sweet. A key diagnostic feature prior to blood tests was sweet urine or glucose in the urine. Okay. This is different from an unrelated condition that does not involve insulin, and that is diabetes insipidus. The key symptom for this disorder is also increased urination, and that's why it shares the first part of the name, diabetes, because there's a lot of urine produced. But the key diagnostic feature in this disorder is insipid or dilute urine. So diabetes insipidus is related to a hormone called antidiuretic hormone, and it is different from diabetes mellitus. The reason I'm even mentioning this is because for the rest of this lecture, I'm going to be using the term diabetes just by itself. And currently, because diabetes mellitus is so common in the community, we just say diabetes. And so that refers to diabetes mellitus, not diabetes insipidus. Okay. So as we always do, a big overview of the system that we're talking about. So diabetes mellitus is all about problems with regulating blood glucose levels. And so let's talk about how this happens normally. Normal blood glucose, and I took this diagram from a biology textbook. This is like freshman level biology, but I loved how simply it summarized all the different moving parts to the system. So normal blood glucose, as you know, is anywhere from 70 to 110 milligrams of glucose per deciliter. When blood glucose is on the way up, so when the GI tract is been absorbing the monosaccharides from digested carbohydrates, the blood glucose starts increasing. It doesn't have to rise outside of this normal range. It just has to be on the trajectory upward. That is a trigger to some of the cells of the pancreas. And you'll remember the pancreas is like the shopping mall of glands. It has a variety of different kinds of glandular cells in it. There are some special cells in the pancreas called the beta cells. Those are the ones that produce insulin and then release insulin when the blood glucose levels start to come up. So the pancreas releases the insulin, and insulin gets into the bloodstream. It's going to go over all of the cells of the body. But the only cells that are going to respond to the insulin are the ones that have insulin receptors on their surface, because insulin is a signal that does nothing by itself. It has to be received by a receptor. The cells that have receptors on them for insulin primarily are the cells of the muscles, tissues around the body, and the cells of the liver. What is triggered to happen is some glucose transporters that were already produced in the cell. They have to be moved and put into that phospholipid bilayer so that glucose can get transported into the cells. That is what insulin does for most of the cells that receive that signal. It allows the cells to bring the glucose out of the bloodstream and into the cells. And they can get stored as glycogen, as we'll talk about shortly. The consequence of this is the blood glucose levels fall. They come back and are maintained in this normal range between 70 and 110 milligrams. Well, after a few hours, the blood glucose is lower than this. The cells had used up the glucose that they had stored, the muscle cells, for example, the neurons. And remember, we said the liver, what does it need with all this glucose? What the liver does is it sops up all the extra glucose. Once the muscle cells and the other cells of the body have taken all they want, the liver sops up all the rest of it. Well, now we want some of that glucose back. And the way we get it back is that when the blood glucose level starts to drop below the normal range, such as after fasting, any period of time that's not eating, that lower blood glucose levels triggers now the alpha cells of the pancreas. These are other cells that also occur in these little islands in the pancreas, and they're producing glucagon. And so that gets released into the bloodstream. And again, it goes all over the body and all the cells are exposed to it, but only the cells with receptors for it are going to respond. And those cells, you guessed it, are in the liver. The hepatocytes are the ones that are going to respond to this signal. And their response is to break down the glycogen. We just put all this glucose together in this polysaccharide called glycogen. And now we're saying, okay, now I need some of that back. So could you like unscrew some of those glucoses off of there and release them into the bloodstream? And so that's what the liver does, is release the glucose back into the bloodstream. The blood glucose level comes back up and keeps us in the normal range. And that is blood glucose homeostasis. These are the moving parts. The pancreas is a big player, the cells, the tissues of the body, and the tissues of the liver. Okay. Now, why on earth do we have such a complicated system? Because we said when the blood sugar is high, insulin is released and the tissues of the body take up the glucose, but the liver acted as a sponge to absorb all this extra glucose. And then just a few hours later, we're knocking on the liver saying, you know, can I have that back? And then the liver just puts it right back where it was, which was in the bloodstream. So what is that about? And what that is about is that the blood glucose, if the blood glucose is too high, it's going to be very damaging to the blood vessels. There are long-term consequences and there are some short-term consequences. When I say long-term consequences, this refers to some of the chronic complications that arise as a result of the extremely high blood glucose levels. And short-term consequences occur acutely. All right, so long-term consequences, it all boils down to the damaged blood vessels. The first three that are listed here are a result of microvascular damage, damage to the capillaries. And the three places we look for it and we see it is in the retina, there's problems with vision, in the kidneys, so there's problems with renal function, and in the nerves. And so there's problems with neuropathies. And then the larger blood vessels, the macrovascular changes, it leads to that damage. We talked about this a long time ago, leads to the damage to the endothelium, and then the cholesterol goes in to try to repair that damage, and we end up with atherosclerosis. And this is then where heart attacks and strokes can occur. Okay, and then the short-term consequences we haven't talked about. The very high blood glucose levels can lead to dehydration. And I don't mean a little bit of dehydration. I mean profound dehydration to the point that the patients are hypovolemic. They lose so much fluid. And we'll talk about what happens in the kidneys that leads to this problem. Okay, so that was when things were working properly. Sometimes things don't work properly. One of the problems that we see is some patients have an inability to produce insulin. They cannot, the blood glucose is coming up, but they are not able to release insulin when they need it. Those patients, that disorder is what we call type 1 diabetes. A different problem that results in some of the same symptoms is when the patients are producing insulin. In fact, sometimes they're producing insane amounts of insulin. They're actually hyperinsulinemic. But the problem is that the cells that are supposed to be responding to the signal, the receptors, are not present in adequate amounts. And the patients become what's known as insulin resistant. So the insulin's being produced, but we're not getting the response that we need. That is what we call type 2 diabetes. And we're going to talk about each of these two conditions separately. And then at the end of all of these lectures, we'll talk about what the consequences are if a patient has uncontrolled type 1 or type 2 diabetes. A quick review of epidemiology. Why am I spending so much time on diabetes when we have a huge chapter? We could cover all these other disorders. This is why. Over 10% of the population in this country have diagnosed diabetes. And there's higher than that amount that have undiagnosed diabetes or even prediabetes, where somebody wouldn't be prescribed medications for it, but the elevated blood glucose is already doing damage to the body. And the rates of diabetes are increasing in young adults and in children. And type 2 diabetes is by far more common than type 1, but both type 1 and type 2 are seeing an increase in numbers, and we're seeing it in younger and younger people. So here's a diagram, or here's a graph of some data from between 2006 and 2016. And this is the most recent data I could find. This is from the CDC website. There's been a significant increase in both cities and rural areas. But we're looking at almost 10% of the population in metropolitan areas, and in rural areas, well over 10% of the population is already diagnosed with diabetes. At least 10% of the population, if not more. You've experienced this, you know. Okay, so that's why we're spending all this time on this. How is diabetes diagnosed? Primarily with glycosylated hemoglobin or glycated hemoglobin, also known as the hemoglobin A1c test. How it works, it's really clever. So in circulation, glucose becomes bound to the hemoglobin. Hemoglobin is a protein, as you know, in the red blood cells. And some of that hemoglobin gets stuck on the red blood cell and on the hemoglobin. And this A1c test measures this buildup. Why? It's not just hemoglobin that the glucose sticks to. The reason that we look at it on the hemoglobin is because the red blood cells, as you know, get recycled. And so we're looking at a relatively fresh crop of cells every 3 to 4 months. And so we can get kind of a update of, you know, how have things been going for the last 3 or 4 months. All right, so you don't expect the hemoglobin A1c values to be 0 because normal blood glucose values aren't 0. So you expect that there's going to be some glucose bound to some of the hemoglobin. I very roughly said 3 to 6%. That's actually not accurate. 3.5% to 6.5% is pretty typical. We like it to be lower than this. 3.5 to 5.5, we would consider normal. Above that, we're starting to have problems. If it gets to 6.5%, that's when somebody gets diagnosed with diabetes. Yeah, normal, the blood glucose levels have been higher than normal for the life of the current red blood cells when somebody's hemoglobin level is this high. Hemoglobin A1c test is that high. All right, so other ways of diagnosing. This is according to the American Diabetes Association. Over 6.5%, as I mentioned, for hemoglobin A1c. You can also be diagnosed based on a fasting plasma glucose level that's over 125 milligrams per deciliter. This is the test that everybody doesn't like. They have to go get a blood test and they can't eat breakfast first. And a reminder, normal 70 to 110. In case you have any trouble remembering that number, what I always think of is, because I've been in education for so long, 70 to A plus, so a C to A plus. And it's not that the A plus is better, it's just that's how I can remember. So 70 to 100, 110. All right, so for fasting, above 126 gets you the diagnosis, or somebody can do an oral glucose tolerance test where they go in fasting, a blood draw is done, they get the really sweet syrupy thing to drink, and then their blood glucose is drawn again at an hour and then again at 2 hours. This is frequently done during pregnancies to check for gestational diabetes. And then the last way is, a patient at any point in the day that shows up in the emergency department with classic symptoms of hyperglycemia, and they have a random plasma glucose of over 200. Then we say, yeah, that person's diabetic. All right, this is it's not a perfect correlation, but what I wanted you to see is A1C values in the normal range. We end up with blood glucose levels relatively normal range. So, 70 to 110. Smack dab in the middle of the range, an A1C of 4.5 correlates to a blood glucose levels of 83. And as you move away, as you get higher and higher, this is what we call the pre-diabetic range. Already damage is being done to the tissues by blood glucoses in this range. Why it's called prediabetes is that people aren't typically prescribed medications at this point. They're cautioned that if something doesn't change in their diet and physical activity, that they're heading to the development of type 2 diabetes. And as you can see, the higher the A1C goes, that correlates to higher and higher blood glucose levels. The normal levels, again, we're talking in the double digits. And why I say this is that patients get used to running in the triple digits and then they see a number under 100 and they panic. But this is normal numbers in the 80s. All right, let's talk in more detail about type 1 diabetes mellitus. We will do a little bit on this now, and then we'll do complications in a separate part of the lecture. All right, a reminder, what we're talking about here is an inability to produce insulin. That is type 1. If the patient is presented with insulin, that is, if they're injected with insulin, their body will respond appropriately to the insulin. The problem is they're not able to make the insulin anymore. Typically, the problem is an autoimmune problem. It's the immune system that's attacking the cells that make the insulin, the beta cells, or it's attacking the insulin itself, or it's attacking one of the enzymes that's involved. Point is, the immune system is malfunctioning. There are antibodies against parts of perfectly functioning tissue. We don't usually, because this doesn't hurt, so we don't usually detect this until almost all of the beta cell function is gone. And so if somebody, remember we said autoimmune systems can run in, or autoimmune problems can run in families, not necessarily the same autoimmune disorder, but if somebody has an autoimmune disorder in the family, if we're kind of looking out for this problem, we may be able to detect the development of type 1 diabetes before the person's in crisis. But often the first sign that the person has diabetes, they're in crisis. There seem to be some genetic predispositions toward it, and there are some environmental factors that contribute to the development of type 1 diabetes. Environmental factors largely having to do with diet, significant increase or significant consumption of a high carbohydrate diet is the environmental factor that's most important here. All right, so the three main consequences of insulin deficiency. The first one, I have several slides dedicated to it. So I labeled it as 1 and 1A, but they're all related to the first consequence. All right, so the first consequence is decreased glucose uptake into the cells. This blue circle represents a cell, and here in red is an insulin receptor. What's supposed to happen is insulin, represented by this purple ball, that insulin is supposed to bind the receptor. In response, the cell is supposed to put a transporter here in the membrane so that the glucose can pass from the extracellular fluid into the cell. That's the way it's supposed to work. But in the absence of insulin, here's the insulin receptor unstimulated. The cell is not aware that there's glucose to be had, and so the transporters are actually in here, and they're not being put into position. So the glucose is present. In fact, there's a lot of glucose out in the extracellular fluid, but it's not getting transported into the cell. And so the blood glucose increases, it stays elevated. So the cells are actually starving, even though there's plenty of glucose available. So the patient is hyperglycemic, but the cells do not have enough fuel. Okay. Related to this is one of the consequences, and we see the problem in the kidney. The problem is called osmotic diuresis, which means that we're losing fluid in the urine due to the concentration of glucose in the tubule. So I think I've shown you this diagram before. The big ball represents a glomerulus. There's a ball of capillaries in the kidney. In gold, that's the Bowman's capsule, and then the renal tubule. You'll remember the stuff that's in the blood, about 20% of all the little stuff passes right out into the renal tubule. That's normal. And also normal is that usually all of the glucose that goes out into the renal tubule, all of that gets reabsorbed. 100% of normal glucose amounts get pulled back. However, there is a limit to how much can get pulled back because there's a finite number of carrier molecules in the membranes. And I'm going to remind you, we talked about this when we were in the renal chapter. These are the sodium glucose co-transporters. Remember we said this was like the sodium was acting like the really hot chick in front of the nightclub, you know, kind of bringing in the friend, you know, getting through. And so the sodium gets pulled back in, and that brings along the glucose with it through these SGL2 transporters. And this was one of the targets for some of the diabetes medications. Okay, so normally all the glucose that's in the blood, some of it comes out into the renal tubule. All of that gets reabsorbed as long as the blood glucose is in the normal range. Between 70 and 110, it should all get reabsorbed. There is that upper limit to how much can get reabsorbed. And in fact, that upper limit is well above what's normal for the normal blood glucose. So this maxes out at 180 milligrams per deciliter, which is well above normal, 110 being the upper limit of normal. So when somebody has glucose showing up in their urine, it's because their blood glucose is well out of the normal range. And so this is what I do for my undergraduate students. How much glucose would you expect to find in the blood of a non-diabetic person? We're talking about blood and somebody that does not have diabetes. So the normal levels would be between 70 and 110 milligrams per deciliter. That's what you would expect in the blood. And then when I ask my undergrads, how much glucose would you expect to find in the urine of a non-diabetic person? Well, since their blood glucose should be here in the normal range, we shouldn't see any glucose in the urine because some of it will come out into the filtrate and all of that should be reabsorbed. And so we should see 0 glucose in the urine. So 0 is the correct answer for the second question. However, when we have somebody who has very elevated blood glucose, the extra glucose that stays here. So the transport maximum was reached. And so some of the glucose stays here in the renal tubule. That has high osmotic pressure. That means it draws water into the tubule, which is where extra water is being drawn in. That's why all the urine, that's why the name diabetes, because all of this extra fluid is being drawn into the renal tubules, which is eventually going to go out of the body as urine. And why mellitus is because here the glucose, the sweet, is still in there. And so when the person urinates, they're losing a lot of water and they're losing some glucose. So the patients end up having measurable glucose in the urine, and they experience huge amounts of urine output, so polyuria. And this is where, if the blood glucose is high enough, this is that acute problem where the patients can become profoundly dehydrated and hypovolemic. This can be an emergency, and I'll talk to you about different circumstances under which this happens. Now we are on to the second consequence of having low insulin. And this one we don't talk about as much. There's decreased potassium uptake into the cells. I mean, everybody knows that glucose is brought into the cells with insulin. What is less well known is that insulin allows the cells to take up potassium. And so, let's see. Let's walk through this again. There's no insulin. So here's the receptor for the insulin. It's not being stimulated. We never put the transporters in, so the glucose doesn't come in, but simultaneously, the potassium doesn't come in either. And so the amount of potassium in the body stays the same, but since it's not getting tucked away in the cells where it's supposed to go, what the patient experiences is hyperkalemia, meaning too much potassium in the blood. The emia part tells you it's in the blood, it's in the extracellular fluid. And that's going to have some consequences, as we shall see. And then the third complication of not having enough insulin is the fat breakdown in adipose tissue, which sounds like a great problem to have, except that it gets to be an extreme problem. So insulin inhibits the breakdown of fat. It actually interferes with lipolysis, the breaking up of fat in the adipose tissue. This is what people are after when they follow a low carbohydrate diet. And so they're trying to limit how much carbohydrate is in their diet so they don't have these big spikes of insulin, so that their adipose tissue will release some lipids, some of the material that's in there. And we'll come back to that point. So if there's a small amount of insulin, decreased amount of insulin, that's good. If there's absent insulin, there's a deficiency, there's not even close to the normal amount of insulin, that is a crisis, because this decreases and in fact in some cases eliminates inhibition of lipolysis altogether. And this allows lipolysis to occur unchecked. That means that bodies waste away. They lose a whole lot of adipose tissue all at once. Sometimes people have described undiagnosed type 1 diabetes as a wasting disease. The person just melts before you. And why that's such a problem, we'll talk about when we get to one of the complications of type 1 diabetes. Yeah, this is not a desirable situation. The having lower amounts of insulin is. Having deficient insulin, not enough insulin at all, that's a crisis. So the clinical manifestations, to wrap this up, patients will report polyuria. They pee all the time. Because they're peeing all the time because of what's happening inside the kidney, where the glucose stays in the tubule and then all of that extra water goes in and they're peeing out all the extra water, they're incredibly thirsty. So polydipsia. Remember, the cells, there's plenty of glucose, but the cells can't transport it in because there's no insulin to tell the cells that there's glucose available. So the cells don't have enough fuel, and the patients report feeling hungry all the time. They're eating a lot, polyphagia, and yet it appears paradoxical that they're actually losing weight simultaneously. When they come to the clinic, what we see is there's glucose in the urine, which you know should not be in there at all. And when we check their blood levels, the glucose is well above the normal 70 to 110 range. Okay. In part 2, we will get to some of the acute complications of type 1 diabetes. See you then.